First session.
Good afternoon to all my teachers. Today I'll be talking on a topic called CAR T cell therapy, which is a newer advancement in the field of immunology and oncology. So it all began in the year 1987 when an Israeli immunologist named Zeli Eshar actually created the first chimeric antigen receptor, which actually does not have any existence in nature. In the year 2010, the first successful cancer treatment with CAR T was carried out with a case of advanced follicular cell lymphoma patient. And in August 2007, US FDA actually approved the first drug, that is designed Leqvizil, which was actually indicated for use in patients of ALL in patients younger than 25 years of age. So back in the times, cancer treatment was all about three heads. It was either surgery, it was either chemotherapy, it was either radiation therapy. In the last decade, we started developing targeted therapies, more specifically with Herceptin-based therapies, where HER2 new receptor positivity actually saw that beneficial effects with drugs like trastuzumab in breast cancer patients. And nowadays, with the advancement of immunology, we can actually see that immune system, which is actually the body's main defense against infection and cancer, can be used as a means of treatment in oncology. So CARs are nothing but recombinant receptors for antigens, which actually redirect the specificity and function of T lymphocytes and help in the management of cancer producing cells. They are also known as artificial T cell receptors, can also be called as chimeric T cell receptors. What we actually do is that the main immune cells, which are known as the T cells, are actually changed to fight cancer in the lab so that they can destroy cancer cells. They are now also known as adoptive cell therapy or gene targeted cell therapy. So this is a wonderful picture of how we actually do a CAR T cell therapy. What we actually do is we do an intravenous line, and then we take out the WBCs, which is also known as leukapheresis. And then what we do is we separate the T cells from the white blood cell count. And then in the lab, it is genetically engineered to pair up with a chimeric antigen receptor, which is then known as CAR T cell. These CAR T cells are left in the lab to multiply. And when they are actually multiplied to a certain extent, the blood is then injected into the patient. So this is how CAR T cell therapy works. But the only thing that we need to understand here, because before we start initiating a patient with CAR T cell therapy, the patient needs to undergo a session of chemotherapy so that we can actually decrease the load of the immune cells so that the CAR T cell therapy has a space to work with. When we talk of the CAR T cell therapies structure, it is basically of three types. It is a transmembrane, an ectodomain, and an endodomain. A transmembrane domain is actually related to the stability of the receptor, whereas the ectodomain consists of the single signal peptide, and the endodomain is the functional end of this CAR T cell structure. When we talk of the timeline, it actually started way back in the year 1992, when it was actually primary engineered CAR T cell engineering. And we've come a long way to the first drug in 2017, which was approved for pediatric acute lymphoblastic leukemia and also for pediatric non-Hodgkin's lymphoma. There are 4 types of CAR T cell receptors, the first, second, third, and fourth, among which first is actually consisting of CD3Z signaling domain. And the third CAR T cell therapy, which is now much in demand, consists of the DAP12 receptor gene. When we talk of clinical significance, as of now, the US FDA has just 2 indications for use of CAR T cell therapy. It is 1 for the use of acute lymphoblastic leukemia, and number 2 for DLBCL, which arises from follicular lymphoma. However, multiple trials are currently underway in conditions like multiple myeloma, hepatocellular carcinomas, and lung cancers. When we talk of side effects, there are multiple side effects. We have multi-system side effects, as in hematological conditions where patients might develop anemia, febrile neutropenia, and also to the extent of developing HLH, which is hemophagocytic lymphangioscytosis. We also have 2 very specific side effects, the cytokine release syndrome and the CAR-related encephalopathy syndrome, which is known as CRESS. Cytokine release syndrome is the most common, which takes place only 1 week after the starting of therapy, and also presents with high fever, low blood pressure, hypoxia, may involve other organs as well. Treatment remains supportive at best. We can use IL-6 antagonists and also corticosteroids. CRESS is a relatively rarer side effect with pathogenesis not clear. might occur within the first 5 days after administration. There are certain questionnaires like the CAR-TOX-10, which helps in diagnosis and assessment of a patient of, with patients of CRES, and management remains similar. So to conclude, CAR T-cell therapy does require a multidisciplinary mode of treatment, and it is very important to know when and how to use as far as CAR T-cell therapy is concerned. And regarding the side effects, the moment we actually understand and recognize side effects early, it is helpful in management of these particular conditions. So thank you, sir.
Thank you.